Ladies and gentlemen, dermatologists, residents and lovers of intricate skin tales, welcome to an exclusive, whimsical journey through the peculiar world of Lichen Striatus, a condition that is as intriguing as its name suggests. Lichen striatus is a self-limited inflammatory dermatosis with a predilection for children, particularly girls aged 5 to 15. It presents as linear, asymptomatic or mildly pruritic plaques that follow the lines of Blaschko, a roadmap of embryonic cell migration hidden in plain sight. Histologically, Lichen striatus reveals a lymphocytic infiltrate at the dermoepidermal junction, reminiscent of lichenoid dermatitis. Key features include vacuolar degeneration of basal keratinocytes and perivascular inflammation. Often with a spongiosis twist, it's a visual symphony for the pathology enthusiast. Clinically, Lichen striatus presents as an abrupt eruption of linear plaques. These lesions often begin as papules, evolve into plaques and fade within a few months to a year. While commonly asymptomatic, some patients may report mild itching. Presenter. Its predilection for following Blaschko's lines gives it a poetic embryological origin story, as if the skin remembers the paths laid out in utero. Diagnosing Lichen striatus is largely clinical, supported by histopathology in ambiguous cases. Here's how we approach it. Clinical examination. Assess for linear distribution along Blaschko's lines. Check for associated pruritus or scaling. Histopathology, if needed, look for classic lichenoid features with civat bodies and perivascular lymphocytes. Differential diagnosis, linear lichen planus, often more pruritic and chronic. Inflammatory linear verrucous epidermal nevus, ILVEN, persistent with verrucous texture, linear morphia indurated with atrophy. Lichen striatus often resolves spontaneously within 6 to 12 months, but symptomatic treatment can help manage pruritus and inflammation. Here's the treatment hierarchy. Treatment protocols: topical therapy, corticosteroids, high potency, like clobetasol for symptomatic plaques, calcineurin inhibitors, tacrolimus for facial or sensitive areas. Systemic therapy rarely needed, oral corticosteroids for severe widespread cases. Adjunctive measures, emollients for hydration and soothing, antihistamines to manage pruritus. Presenter. Remember, the cornerstone of treatment is reassurance. Explaining the self-limiting nature of Lichen striatus can often be more therapeutic than any medication. The prognosis is excellent, with spontaneous resolution in most cases. Nail involvement, while rare, can lead to temporary dystrophy, and though recurrence is rare, it's not unheard of. Key takeaways. Self-limiting condition with minimal recurrence. Blaschko's lines, a critical diagnostic clue. Histopathology reserved for atypical cases. Treatment, symptomatic relief and patient education. Dermatology is where art meets science, and conditions like Lichen striatus remind us of the beauty hidden in complexity. Thank you for joining me on this journey. Stay curious, stay inspired.